Yeah.
You can see perfectly.
Yeah, okay.
Thank you.
Perfect. Okay. So, yes, so as I say, it's not another typical talk about febrile convulsions. We'll try to discuss a little bit more infrequently encountered conditions. My objectives for today, as I say, we'll talk about some tips on different conditions mimicking febrile convulsions. My focus will be mainly on recognition and early management. So I'm not going into the details. Some of these conditions need very separate lectures, like, many lectures probably on a few of them. But I'll try to do as quick as I can, sort of like summary and to just touch base about them. So fever and seizures, they are quite like, I would say happening at the same time in many conditions. It's not very specific to any single condition, and the differential underlying them is quite broad. And when we say febrile convulsions, usually like the first thing that comes to your mind is simple febrile convulsions, which are typically short duration, 10, 15 minutes or less, generalized seizures. So it's not focal, not recurring within 24 hours during febrile illness, and not caused by an acute disease or infection of the CNS, and usually in children between 6 months to 5 years of age. No neurological deficits and no previous afebrile seizures. So there are not known epileptic children who come with febrile seizures as a relapsing presentation. And then comes the term of complex febrile seizures, which could be focal or generalized, usually more prolonged, more than 15 minutes, can recur within 24 hours, which is not what happens with the simple ones, and can and or associated with post-ictal neurological abnormalities. So it could be like prolonged weakness on one side of the body and so, or encephalopathic picture and so on. And probably this is a more generalized term and includes many conditions that can fall under this sort of umbrella of the complex febrile seizures. And probably this would be what we were talking about today. There's what's called febrile convulsions. If you came across that before, and we could see some children who are usually presenting with mild gastroenteritis sort of illness, usually like with rotavirus. They are usually afebrile. They are very healthy children, and no previous medical issues, and there's no ongoing current acute CNS infection, dehydration, or electrolyte imbalance. Usually, the outcome in these cases are very good. They recover very quickly. And usually, I mean, not usually, I'd say in a few of them, you can see some specific finding on the MRI. Like this is what's called splenium of the corpus callosum. So the corpus callosum is what connects between your right and left hemispheres of the brain. So this is the tail or the posterior part of the corpus callosum. This is the front side or the anterior part of the corpus callosum. So at the splenium, you can see some diffusion restriction on the DWI images, and this is like on the FLAIR images. You can see some hyper intense lesion here. This is very benign. It looks scary, but actually they recover very well in a couple of days, and it has very good prognosis. It has funny names, so cytotoxic lesions of the corpus callosum. Obviously, it is a name for that finding, which has many causes. It's not only about the febrile convulsion, it's just one of the causes, but it might be interesting for you to familiarize yourself with the long list of the differentials. I came across this condition like probably 3 times now. There is what's called also MERS, or mild encephalopathy with reversible splenial lesion. Again, similar radiological finding, and they present in a bit mild encephalopathic picture, a bit sleepy. And again, they recover very well within a couple of days. So I'll start by some case presentations, probably just for brainstorming. There's no right or wrong answers. Okay, so feel free to just put your probably like in the chat. You can put your comments about what you feel. So this is a case of 2-year-old child, previously fit and well. You have seen in the ED coming with ongoing generalized tonic-clonic convulsions, has been for 20 minutes or more. The child is febrile. He had 2 rescue benzodiazepines and they stopped, and currently the child is asleep and no more seizures. So what questions do you think would be the first thing, or not the first thing, what sort of questions you will try to ask the family about to try to identify or narrow the differential in this case? If you want to leave any comments in the chat, please. I'm not sure if I can see the chat.
Okay, we've got someone writing up history of fever.
Okay.
Some,
There's history of fever. Yeah.
yeah,
Oh,
and
previously. Yeah. Okay.
yeah, and the other one is writing first time or recurrent,
Okay.
non-epileptic or
It's
not.
first time,
Yeah.
not non-epileptic. No. Yeah. Okay. Good input so far. Is that what you? Yeah. Okay. Okay. So probably my learning point I would just want to highlight in this case is, and this is very frequent scenario, by the way, it's not the first time. I mean, like, I'm sure all of us will come across this, is you go and review a child who has, everyone says or hand over to you that this is a generalized tonic-clonic convulsion, but no one will mention about the onset. How did it start? So you just see the snapshot or at the part or the, like at the time of the bilateral tonic-clonic convulsions. But was it like, I usually I'm very minded about the onset of these seizures, if it started as focal or not. And obviously, this is for clear reasons, because it gives you some idea as well about the underlying pathology. So typically in simple febrile, or even like in, I would say, simple complex febrile convulsions, even if it is a bit prolonged, but ideally they are generalized, less commonly to be focal. And I should be a bit cautious and, concerned. And this will bring the second question, which is like what I'm going to do. And again, this is a child in the ED. If I have suspicion that this was a focal sort of like onset convulsion, I'll try to do an acute imaging. I will not just leave them to recover. I'll try to do it as soon as I can. And this was like an MRI, and this is not an actual case, but obviously we have met cases similarly. They present just with seizures, probably with some low-grade temperature, and people thought that this is just some febrile convulsion. Ended up with a CT head, and as you can see, there is a significant hypodense area in the middle part of the left hemisphere, which indicates a left MCA infarct. So they had a stroke, basically. And this is one of the things, even the RCPCH are fighting, like, or significantly advocating for the idea that strokes can happen in children. So if you look at the awareness posters on the RCPCH website for stroke, it just says, like, it can happen in children, like stroke can happen in children. There's no other message, like, just please be aware or keep it on your differential list and so on. And there is a very extensive guideline, I think from 2017. You can familiarize yourself, and I find it very useful in general. You will not use it every single day, but obviously, if you come across a patient with a stroke and you want to have a quick look at what to do as a first step, second step, I will invite you to have a read of that. So the first learning point, I would say, stroke in children can mimic complex or focal febrile seizures, especially in infants. So especially at young age, it can present with a focal seizure, especially prolonged, and can have some focal, can febrile element as well. Another case, 1-year-old seen in the emergency department, like 20-minute generalized tonic-clonic seizure, stopped after the second benzodiazepine, whatever sort of benzodiazepine you use, previous multiple generalized febrile convulsions, previous one admission to PICU with seizures. There was no infection at the time. The child was like sent home. He's currently back to normal. Seizures stopped. He's alert, not encephalopathic, no ongoing seizures. Would you be concerned about this child? Okay, let's ask it in that way. Would you think that this child is okay just to carry on with whatever they do in life, or do you think that you need to do a bit more investigation, and you just think that this is a child, or do you think this is just a child who is just unlucky to have frequent febrile convulsions in their life? If you have any comments, please leave in the chat.
History implies more assessments needed by Mahmoud
Okay.
Aslan. And then Wagih
Okay.
Al-Khouly is saying feverish or not.
Yeah, he present with fever. Did I say that? Previous multiple. Yeah, he is feverish now as well. Yeah. We are talking about febrile convulsions, so I'm trying to stick to the topic. Thank you. It started generalized. Started as generalized tonic-clonic. Are you still concerned or not? Okay, I will just jump to the answers just for the sake of time. So obviously, I will be concerned about this child, and again, this is a common thing that we come across, that those children keep coming and being sent home. And because their LPs are normal, there's no CNS infection, they're just a bit unlucky. They have a family history probably of like, of easy or like recurrent febrile convulsions in one of their parents. And people will think just like, it's just in their genes or something. But obviously, this is not an enough answer. So in these patients, I'll try firstly to take a good developmental history. Has been there any recent developmental regression, or has been there any concerns about development at all? And I have to say, sorry, Ahmed and Mahmoud, PIC are not usually very good like taking developmental history. So usually you focus on the main issue, which is happening, which is great, but like you need to. Usually, when we come as like neurologists, we find that admission history is usually lacking the developmental history, which is, I would say, vital usually in these cases. Similarly for family history as well. I'm not
I
talking about you,
can
by the way. I'm sure you're doing great.
no, no, I can say that's why we call you in.
Yeah, to take history for you. So, yes, so I will be concerned, obviously, about this child, and I will think about genetic causes usually. And when we say genetics, most commonly like something like Dravet, CN1A, genetic epilepsy with febrile seizures plus, or GIFs plus, or PCDH19, which is like, you don't have to really worry about the names of all of these. You just need to have that feeling that there is something wrong, so you do not have to think what is the exact underlying etiology or genetic cause, but you have to think that this is likely to be of a background or underlying genetic disorder. So developmental and family history are vital. And I'll just touch base a little bit about Dravet syndrome very quickly, because it's probably SCN1A is the most commonly encountered sort of genetic mutation epilepsy disorder. So usually it happens in the first year of life. And usually when you ask anyone about Dravet syndrome, what do you know about it? If they have some information, they would say, yes, it presents in first year of life, developmentally delayed child, hemiclonic seizures, or like focal clonic seizures. Which is not very true, because the recent evidence, we know that it is mainly tonic-clonic, so it could be bilateral actually. Hemiclonic is less common, even less common for focal impaired awareness, seizures, or myoclonic or tonic or absences. Initial seizures is febrile only in 55% of children, so it means 45% of patients can present to you without even febrile convulsions, and they still have Dravet syndrome. Can be vaccine triggered. So again, taking history if there was any recent infections or recent vaccines given. Development could be normal in the first year of life and becomes more difficult or regressing after probably the first year and after starting having seizures as well. So this is a very, very quick overview of Dravet syndrome. Again, they are frequent visitors, I would say, of PICU. I'm sure people who work in the intensive care will agree if you have seen at least the gene mutation SCN1A. Also, metabolic causes are important to be considered for every patient coming with prolonged febrile-related seizure. And again, history is very important. If there has been any history of developmental delay, if this happens, like having such prolonged seizures with every febrile illness, or this is the first time. So I'll always keep metabolic causes at the back of my mind. You will do some routine. I wouldn't say routines. I'd say like baseline sort of metabolic assessment investigations, including electrolytes, blood gas, ammonia, plasma amino acids, urine organic acids, lactates, acyl carnitines, and finally genetics if strong suspicions. And usually this is like with some mitochondrial conditions like MELAS, for example, so they can present with focal neurological symptoms, including seizures. So always keep that in mind and just have some suspicion, especially if you see like some raised lactates on your blood gas or something. So you have to start feeling that it could be a metabolic condition underlying. Third case is a 5-year-old, previously fit and well, fever for a few days, seen in the ED with 20-minute generalized tonic-clonic seizure, self-terminated. The child remained encephalopathic for extended period. You did some acute imaging, normal CT head, and then you decided to do an LP. So the LP showed raised white blood cells of 60. No red blood cells, was mainly lymphocytic. There was raised protein. Started on triple antibiotics, and by like 48 hours, the bacterial cultures came as negative, and viral PCRs as well came back as negative. Okay. Uh, what is your next step, and would you stop the treatment? And just as some context, the child is still unwell. They are still encephalopathic. They are not having seizures, but they do not look right to you. You feel something is still wrong. What would be your approach, if you don't mind sharing in the chat again, please? Thank you.
Okay, so we have MRI, we have treat as bacterial meningitis, we have
Okay.
MRI again.
Okay. Okay. MRI is normal, let's say.
Steroid,
Okay.
you're not going to be judged for it, guys. You can keep
No, no,
putting
yeah, yeah.
putting ideas.
All correct, all correct.
Yeah. IVIG has been added.
Okay, anti-NMDA I can read. Yeah, polygonal band, yeah, oligoclonal bands. Yeah. Treat as meningitis. Okay. I mean, okay. So, I mean, do you feel this is more sort of like bacterial or viral sort of picture, based on the CSF result? I mean, with cultures, with negative cultures, do you still feel that this is bacterial meningitis? Because I could see that comment a couple of times. And with normal MRI. Okay, so I will just jump to the answers again for the sake of time. So for me, it doesn't sound very bacterial, considering the I mean predominant lymphocytic white blood cells, and again negative cultures for the bacteria. So usually that, unless like in very very rare conditions, but in general, no, it was not taken on antibiotics. I see some comment. But yeah, it was done before the antibiotics. However, again, I have the feeling that this is still an infectious, or there is an infectious underlying disorder. And the message I want to give here is, what did I do here? That I would still have suspicions for a viral encephalitis in this case, plus others, as you said as well. So I might consider repeating the LP, especially if there's suspicion about HSV, and HSV can be early negative. So repeating the LP could be an option sometimes. You mentioned about MRI, which is extremely correct. Definitely, I would do an MRI in this case. I would do an EEG as well. And in EEGs, again, as I said here, like if clinical suspected, and this can include any MRI changes like temporal lobe changes, for example, which might not be there, but if it was there, it would be very suggestive. If EEG is showing as well, like some EEG, some temporal lobe predominant abnormal waves, again, I will be a bit suspicious about HSV in this case. But just the message to take home is like, initial LP, if you're suspecting HSV encephalitis, or again, talking about clinical suspicion, if there's like cold sores or in contact with anyone with like some skin lesions, I would be extremely suspicious about that. So always consider repeating the LP. Obviously, alternative causes, as all of you or most of you said about the autoimmune causes, which we are going to touch base in more detail. So when to suspect HSV encephalitis, probably I just said about the neurological picture between seizures, encephalopathy, skin examination, contact CSF with predominant lymphocytes and raised proteins. Imaging, if there is, I mean, it's not always there, but sometimes you see some temporal loop changes, and obviously EEG as well. We will go through more details soon about the autoimmune things, but I would say for the case for it's similar, like I tell, it's similar age, like young child with had similar story, like infections, sorry, seizures settled, and now they are encephalopathic, and the LP shows white blood cells of 10, mainly lymphocytic as well. And then you did the CSF PCRs came back positive for HHV6. What is your conclusion, and what would you treat? Do you think this is HHV6 encephalitis, let's say? Yes, no, not sure. Any comments?
I think everyone is
Okay.
worried. That's a trick question, you know? It
I
feels
keep
like
doing it, right?
it
Yeah,
really feels like a trick question.
isn't it? Yeah. Okay. I mean, because the answer cannot be just there, right? Yeah, so it should be
Yeah.
something else. So I would say just about HHV6 in particular. So all the viruses, when you have the viral infection, they clear out from your body at the end, right? So they get treated, or just your immune system just kills them. It does not stay there, right? However, for HHV6, it has a very interesting ability, which is called chromosomal integration. So the DNA of the virus can integrate into the DNA of yourself or your parents, and this can get passed through the generations into the second generations. So this could be a false positive test. So ideally, you have to interpret the result like with extreme caution, like looking at the whole context and the clinical picture. Is this child really behaving as like an encephalitis patient, and usually ask questions about like viral load, so it's not just about being positive, but ideally you need to get some idea from your lab how positive it is it extremely positive? There are usually reference numbers. I'm not going through that, but just keep in mind that HHV6 in particular, it does not necessarily mean automatically that this is HHV6 related encephalitis. It's more common in immune compromised children like on chemotherapies and so on. In previously normal child, extremely rare. So always be careful about this. So as a key pitfall, as I say here, chromosomal integration is some phenomena that happens with the HHV6. That I said, assess viral load. Consider a hair follicle testing, and this is an interesting test that you can do if in extreme suspicion, like, and you're not sure. So basically, if the PCR, which is testing for the DNA, is tested positive in the CSF, theoretically it should not be in other places in your body, like in your hair or your skin or your saliva, for example. So you test in two different areas, particularly in the hair follicle. And if it came from a previous generation, like from one of your parents, let's say, or even a pre inactive infection from all time ago, it should not be tested positive in the hair. It should be tested positive in the hair follicle if it came from a previous generation. However, if this is an acute infection, it should be only in the CSF. So I'm sure, Ahmed, for example, you came across like HHV6 encephalitis like in PICU, and yeah, it just is positive for some reason from time to time. So I would say just for everyone to be aware. Uh, Case five, what slide am I on? So yeah, I think I'm doing well with my time, so I'm just in the middle, and I still have a bit more time. Case five, 2-year-old child presented with fever, seizures, and which stopped after the first dose of benzodiazepine, has been like prolonged, like encephalopatic for a prolonged period. You did some LP, and the LP was unremarkable. You did an MRI, okay, and the MRI shows some changes, and this is some hyper intense lesions in the white matter, probably left, and a bit less on the right lobe as well. Any early impressions before we move on? Yes, someone said Adam. Yeah, perfect. So obviously there will be a differential diagnosis, but this is very likely to be ADEM, or acute disseminated encephalomyelitis, which is typically subacute presentation with encephalopathy and multifocal neurological symptoms. And the MRI can show white matter diffuse, poorly demarcated large lesions, the ones that I just displayed, and can also show deep gray matter lesions, mainly at the thalamus or basal ganglia. Like this one, for example, it looks less marked, but you can see this is the thalamus on both sides, and these are the hyperintense lesions on the flare sequence. What I want to talk about ADEM today, and this is a very important message as well, that 90% of them are monophasic, that it just happens once in life, and 10% can be multiphasic. And when I say multiphasic, I mean that it can happen multiple times in life. And if it is multiphasic, do you have any impressions what could that mean in terms of diagnosis, or would it change your mind that this is a case of ADEM or something else? Okay, someone says multiple sclerosis. Okay, good. Anything else? Okay, yeah, perfect. Okay, so I think you're doing very well. So it can indicate basically an underlying neuroinflammatory disorder, and as you mentioned, multiple sclerosis, MOG antibody disease, and also neuromyelitis optica spectrum disorder. It's not common for MS to present as multiphasic, so usually it's once. However, there is a high chance that it's more linked to MOG antibody disease, I'd say. And usually what happens is this patient presents like, first time or one episode of MOG, of ADEM, and receives the treatment, the standard like, IV methylpred or IV steroids, whatever form you have, IVIG and plasma exchange. Again, like there's no specific guideline, whatever your unit or your hospital will use. And probably the reason I included this case here is just to highlight that ADEM and probably most of the encephalopathy cases of no definite infectious cause need a bit of more investigation. So it's not just to treat the current episode. Always think, is there any other condition that could be underlying? And ADEM could be just a presentation, could be just, like the face of a much bigger underlying condition that might need long-term treatment or, like some different treatment management plans, like in neuromyelitis optica, for example. So it has different management strategy. So what tests will you do, and will it be serum or CSF? Considering that you mentioned already some differential diagnosis, if anyone wants to share. Yeah, oligoclonal bands. Yeah, okay. And CSF or serum? Or who answered? CSF only? Why not serum? Okay, perfect. Yeah. Right. Okay. Can continue. As you mentioned already about the oligoclonal bands, and you mentioned about the conditions as well. So like MOG, aquaporin 4, and as I mentioned here, as save a sample, because sometimes they test negative, and I'd say the phenotype or the clinical picture evolve or change, and then you start thinking about extra sort of like conditions that can explain, because they are not the only neuroinflammatory condition that can present. I will just, before I move to the second point, which I want to mention, I'll just mention that you always try to include a spinal MRI in the suspected cases, even if they present with encephalopathy and you do not know about the lower limb weakness, for example, or anything like that. I will try still to do a spinal MRI, because in lots of these cases, the diagnosis lies in the spinal MRIs. And if we have the chance later on, not today, we can go through that in more detail. And I just wanted to show this image about the oligoclonal bands in particular. So for the other tests, because I asked it in CSF or serum, for the other tests, it's typically in the serum, and this has been the practice till last couple of years. More recently, we recognize that some cases might have just a CNS or CSF localized. So you will try to do them in CSF as well. And would be my practice myself. Some people might still do them just in the serum, except for oligoclonal bands. Obviously, it is the only test that you cannot do in one fluid, so it needs to be on both of them, because it's based on the comparison between it's by name, it's called bands. So they look at these bands which represent the antibodies synthesis within the serum and the CSF, and they compare between the serum and CSF. So here there are no particular bands you can see. However, here you can see some bands on the CSF and not on the serum, and this was called type 2. And it basically means that there is intrathecal synthesis of antibodies, which could mean there is an underlying neuroinflammatory condition, as you mentioned about MS or MOG or neuromalacia optica, or even anti-NMDA, as Wajih is saying. There is type 3, which could be in both of them, and this could happen like in systemic illnesses, for example, but they are not the same. It could be type 4, they are exactly the same, but it does not necessarily mean, I mean, like all the other types, it does not mean there is an exclusive intrathecal synthesis. So type 2 is the most sensitive. The other ones are questionable, I would say. Case 6, I'll try to go quicker here. So 12-year-old male, fit and well, fever for 1-2 weeks ago. Currently not febrile, but there has been recent change of personality, poor sleep over the last few days. Presented today with ongoing generalized tonic-clonic convulsions around 20 minutes, stopped after 1 dose of benzodiazepine, and currently the child is asleep. Okay, so no more seizures, just drowsy probably after the benzodiazepines. And what would be your next steps? Should I wait for comments or should I? 12 years, yeah, 12 years, male. Anyone wants to share? Is that from now? Okay, yeah, perfect. So I'm idle of months. I cannot, I don't know. Anti-NMDA, yes, that's perfect. So it's more likely to be anti-NMDA. However, also you usually consider infections because viruses can present similarly. So always try to rule out infections, consider triple antibiotics, and rule out potential causes. But at the end, it might be an anti-NMDA, which is a very standard sort of like presentation. Usually try to send antibodies again, and mainly in serum, would be in CSF paired. In EEG, it might show what's called extreme delta brush, which is a very characteristic finding in this case, although it's not necessarily there all the time. And MRI can show not very specific, but some changes that can suggest the diagnosis as well. I will stop here at the autoimmune encephalitis. I'm not finished yet. I still have like one last case, but just for your knowledge, I think this review or this paper is very popular for anyone like reading or want to learn about autoimmune encephalitis, and probably you might want to have a look at that because it defines as well. It categorizes them into like probable, possible, and definite autoimmune encephalitis, and gives you some idea about the investigations. And it has very nice tables, so it's very practical as well, if you want to make note of that. Okay. And then I think this is my last case today. Case 7, a 10-year-old child, fever and ongoing seizures, more than 2 hours in the emergency department, failed 2 benzodiazepines, and then you give even like IV levetiracetam or Keppra and phenytoin, probably phenobarb if you do not use levetiracetam, or even valproate. So basically it has been like treatment refractory, and you decided to intubate and ventilate and admit to the PICU. Child has been on sedation and muscle relaxants. You did the CT head as acute imaging, which was normal. You did an LP, and the results at 24 hours were reported as normal as well. Nothing obvious you can see. The child obviously has normal history, so there was no history of any infections before or any epilepsy. You try to start weaning the sedation by day 2, and you can still see ongoing seizures. So what do you think is happening, and what would be your next steps? Is that comment about autoimmune encephalitis from now?
I think the comment was from before. The new
Yeah.
comment is about MRI, MRA, MRV.
Let's say done and normal. Super refractory seizures. Okay. MRI, normal. EEG is showing ongoing seizures. That's a good point. And probably I wanted to mention about the CFAM that the team here has a very nice lecture, or what do you call, Ahmed, meeting about CFAM teaching.
Yeah.
Right.
Yeah,
Okay.
we had the previous talk about CFAM from one of the experts in the field in PICU.
Yeah.
It's on our channel. I'm gonna put the links for everything that is related.
Yeah. I think it's very, very informative. I learned a lot myself. About metabolic causes, that's a good point. So you start investigating, basically. Okay. And what will be your diagnosis at this point? I mean, you do not have any evidence of any condition. Okay, so I'll move on. I'll move on. Okay, so I think just like to mention about the because it's a trending topic nowadays about NORS or fires. So starting with refractory states epilepticus, as mentioned in the chat, is by definition is a failure to respond to adequate treatments with first and second line anti-epileptic drugs. And this means not two benzos. It means like a benzo and a decent second line as phenytoin or phenobarb or Keppra, levetiracetam, or like sodium valproate. And then comes the definition of NORS or new onset refractory status epilepticus. So it is a refractory status epilepticus, but no active epilepsy or pre-existent relevant neurological disorder without a clear acute or active structural, toxic, or metabolic cause. So you try to do your workup and there is nothing there, and there is still ongoing refractory status. And there is what's called FIRES, which is febrile infection-related epilepsy syndrome. So it's considered as a subcategory of NORS, although like both names could be used interchangeably. Usually there is a prior febrile infection, 1 day up to 2 weeks prior to onset of refractory status, with or without fever at the onset of status epilepticus. So the child can still present without fever, but they have treatment refractory status epilepticus. Again, with no background history of a neurological disorder, and your initial workup is normal. So, so it's not a diagnosis. So you cannot say this is a case of NORS or fires and you stop. So it's just an invitation to further investigate, and it gives you some guidance as well into term of treatment. So it's a clinical presentation. It's not a final diagnosis, and can be due to an underlying pathology still. So you still need to keep investigating. However, if there is no explanation, it can be considered as cryptogenic NORS or NORS of unknown etiology. Okay, and that's important because treatment-wise will depend a lot on that. So if in the first as a first line sort of treatment, and this should be started within 72 hours. And of course, we are talking about like if you do not manage to find an underlying pathology. So it's not like, you do not see radiological findings that can suggest autoimmune encephalitis, let's say, or there is no evidence of infection, so you start have to think about what else I can do. Still, it would be considered as cryptogenic at this point. And for the first, as a first line within the first 72 hours, obviously it will be between like IV methylpred or steroids, IVIG. Plasma exchange is not well established, or there's no much evidence to suggest. But you can give both of them as IVIG and steroids can be given at the same time in these cases. As I said, no strong evidence for plasma exchange. And ketogenic diet should be initiated in the first week. So, and probably that's a big message to people working in ICU, that ketogenic diet, even through parenteral nutrition, can be considered not necessarily enteral as well. And it has a huge effect. And obviously, like the earlier you treat, the better the final outcomes. Second line should be started within 7 days of seizure onset. And I know this might be a bit difficult depending on where you work and what sort of like available treatment options. But as said here, should be based on suspected etiology. Obviously, it's not if a pathogenic antibody is identified or highly suspected, so rituximab. So like if we think, when I say a pathogenic antibody, like when we talk about the autoimmune encephalitis cases, so rituximab should be started. If cryptogenic, so ideally they respond to cytokine like sort of antagonists, like interleukin 1 as anakinra or interleukin 6 as tocilizumab, should be initiated as well. And as I mentioned about the cytokines, it's a very huge biomarker, though it's still like used probably within research contexts, but there's not much knowledge to say. However, there is a consensus, and there are some national guidelines regarding managing cases of fires and NORS. You can familiarize yourself with them. Obviously, other causes we do not talk about today, like including toxic. So usually do urine toxicology for any case presented with like new onset seizures, febrile convulsions, atypical febrile and quite encephalopathic, let's say, electrolyte imbalances, PRES or pseudo-reversible syndrome, and obviously any structural lesions, and as you said, like doing the MRIs, CTs, and so on. This is just a table summarizing the different causes as well of acute and subacute encephalopathy in children in particular. It's within the upcoming national encephalitis guidelines in the UK. And some final messages: stroke can mimic a febrile seizure, as we presented in the first case. Development and family history are vital, so always make sure to rule out genetic and metabolic, at least at the back of your mind, as I say, and have some raised suspicions based on the initial lab investigations. HSV can be early negative. Always consider repeating the testing if clinical suspicion. As I mentioned about the HHV6, PCR does not always mean that this is a HHV6 encephalitis. Autoimmune encephalitis should always be in your list of differential. So not all of the cases are CNS infections. So even if you are like having some early suspicions of CNS infection and you're waiting for some lab results, ideally we take a sample and just save it aside. Like, in case of the infection panel comes back as negative, I will be able to process an earlier taken sample without having to do another LP. So always, I think it's a common it's a standard practice nowadays, at least in the UK. People will keep autoimmune encephalitis on their list of differentials from an early time. And as I say here, always be skeptical about reported normal MRI. So especially this for people who do not work in very well-established systems, that when you get a reported normal MRI does not necessarily mean that this is a normal MRI. So always, even like for us, we still, so the initial MRI could be reported by a non-neuroradiologist, and then it's reported by a neuroradiologist, and then we take it further to like a big MDT meeting discussing the MRIs even further. So, and in many occasions, we still see findings that could be wrongly reported initially as normal, and then we find very subtle findings. So always be skeptical about the initially reported MRI, which could not be normal. And this is the end of my slides, and feel free to contact me if you have any questions, and thank you.